Dr. Mullen is board certified in neurology and headache medicine. Dr. Mullen is also trained in Botox injection for headache, nerve blocks and trigger point injections, and has a special interest in hormonal migraines. Dr. Mullen, would you like to begin?
Hi everyone, thank you for having me. I'm happy to be here. So chronic daily headache is a very broad topic to touch on briefly, but I'm going to do my best to just give you a synopsis of what we look for in chronic daily headache, the differential diagnosis, and then very briefly sort of brush strokes on how we go about treatment. So just disclosures, I have no conflicts of interest. Everything that I'm talking about is evidence-based medicine. So whenever I see a patient in my practice who comes in with a new onset daily headache, before I look into the differential diagnosis of primary headaches, you have to worry about and rule out secondary headaches. So secondary headaches are headaches that are secondary to an underlying pathology, such as an infection, inflammation, a neoplasm. And the way that we go about looking into it is by initially taking a very detailed history and a thorough physical examination, including a full neurologic exam. And we look for red flags. And I'll go into the red flags of both the history and physical in a minute. If the patient has no red flags, then we can safely say that we're looking at a primary headache disorder. However, if they do have red flags, or if they might have primary headache but there are some atypical features, then you definitely want to investigate further the possibility of a secondary headache. And to do that, you usually go into some diagnostic testing. So these are the red flags to which I referred. So we SNOOP out the red flags, and SNOOP is the acronym that we use to think of worrisome signs and symptoms. So the first S is systemic symptoms. So does the patient come in with not only new onset headaches, but also perhaps fever or weight loss? Do they have a secondary risk factor, so an underlying disease or reason to have a secondary headache, like HIV or primary malignancy? The N is neurologic symptoms. So do they have an abnormal neurologic exam? Are they confused? Are they having memory problems? Do they have numbness or weakness that's there consistently on one side of the body? The onset of the headache. So when a headache comes on abruptly, the time to peak being usually less than 1 minute, that's always worrisome, and we always want to look into a secondary diagnosis before we give them a diagnosis of a primary chronic daily headache. Are the patients older? So any patient that's presenting for the first time with a new onset daily headache greater than the age of 50, because it's unusual to present at that age, you always want to look into secondary causes and make sure that you are in fact dealing with a primary chronic daily headache. And then finally the P's. So what is the pattern? Is the headache pattern progressive? Do they start getting one headache a week and then very quickly developed into a daily headache? Are there precipitators, meaning certain triggers, like coughing or sneezing or bending forward? If they have any of these indications, you worry about an increase in intracranial pressure, and therefore you would again go about with a diagnostic workup. Is it positional? So headaches can be related to pressure changes, and standing up and lying down affects the pressure within the skull and often can trigger headaches. And finally, do they have papilledema? Papilledema is a condition of a blurring of the optic discs, and it's generally an indication to a neurologist when they're doing an exam that there might be increased intracranial pressure, and that might therefore be the reason for the daily headaches. So when I refer to diagnostic workup, the workup is very variable. It really depends greatly on what the physician finds on their exam and the history that's given. But generally, an MRI can be done. We also sometimes do an MRA, which looks at the arteries. The MRI looks at the tissue of the brain. An MRA looks at the arteries that supply the brain. And in lesser circumstances, we do something called an MRV, which is a venogram, which looks at the veins that drain the vein. So depending on the patient and their history, we can do any number of those imaging studies. Sometimes routine blood tests, anemia can cause a chronic daily headache. Thyroid dysfunction can cause daily headaches. Liver function abnormalities, renal function abnormalities, inflammatory markers, which is the ESR and the CRP. We like to check those, especially in elderly patients, because that can be a sign of a secondary headache. We occasionally check Lyme disease, although it depends on if the patient lives in an endemic area. We may progress on to a lumbar puncture if the physician's suspicion is high enough and the tests that I've already described have been negative, sometimes we will move on to a spinal tap or a lumbar puncture, and we obtain spinal fluid and look for signs of inflammation as well as signs of infection. And then finally, we might refer to an ophthalmologist or an eye doctor or an ENT if there's strong indication that the sinuses are involved or that the eyes are involved, to get them to do a thorough exam and rule out any secondary pathology coming from those systems. Once we have ruled out secondary headache, we then land on a differential diagnosis of primary chronic daily headaches. So just to be clear, as of yet, this is not a recognizable international classification of a headache. However, it's used very commonly in clinical practice. So when we say chronic daily headache, what we're referring to is a patient that suffers from greater than or equal to 15 headache days a month for at least 3 consecutive months. And then further in that category, we divide it into primary short duration headaches and long duration headaches. So the short duration headaches I'm just going to touch on here. For the most part in clinical practice, we see long duration headaches, so that's what I'm going to focus on for the rest of the talk. The short duration headaches can be chronic cluster headache, a headache called SUNCT, and paroxysmal hemicrania. All of these headaches are unilateral and involve autonomic features, which includes redness of an eye, tearing of an eye, running of a nostril, and then finally hypnic headache. And again, these headaches can occur on a daily basis for 15 or more days a month, but each episode is less than 4 hours. The long duration headaches, which again we see much more frequently in clinical practice, each episodic headache is longer than 4 hours, and for many patients, one headache blurs into another, and there really is no end of one headache and beginning of another. So under that category, we have chronic migraine, chronic tension type headache, Hemicrania Continua, and new daily persistent headache. And I'm going into each of these more thoroughly right now. So the first is chronic migraine, by far what I see most often in my practice. And the definition is a headache. It can either feel tension type and or migrainous quality on 15 or more days per month for at least 3 months. The patient must have had at least 5 prior attacks of clear-cut migraine without aura prior to the daily onset. On 8 of those 15 days, they must have migrainous features. So migrainous features are pulsatile, associated with nausea, light and sound sensitivity, that's the photo or phonophobia, and aggravated by routine physical activity. So while they have 15 days of headache, 7 of them can feel tension type, but there have to be 8 headache days that fulfill the classification for migraine. And again, they cannot have the presence of medication overuse. And I'll get into exactly what medication overuse is and how we diagnose that in a minute. So chronic tension type headache has a very different classification criteria. So they must have at least 15 episodes prior to the onset of the daily headache of the following headaches. And then once they get these headaches daily, they must be at least 15 days a month for at least 3 consecutive months. So these headaches are bilateral, whereas migraines are unilateral. They're not pulsating, but rather more of a pressure or a band-like sensation around the head. The intensity is mild to moderate, whereas migraines are generally severe. It's not aggravated by routine physical activity. So tension type headache patients are often able to go about their routines, fulfill their necessary duties, whereas often migraine patients have to go home from work, put themselves in a dark, quiet room, and often even sleep. These headaches can be continuous, but they must last at least a few hours. Again, 4 hours for the diagnosis of long duration. And there's no severe nausea, no vomiting. So I emphasize severe because tension type headache patients can have some nausea, but it should be mild and it should never lead to vomiting. So again, the lines can get blurred because chronic migraine, you're allowed to have some tension type headache days. So just to help further differentiate, so chronic migraine should have GI, meaning gastrointestinal, nausea, vomiting, as well as neurologic symptoms. Chronic migraine usually can have a menstrual aggravation, meaning that the headaches are more frequent and more severe around a woman's menstrual period. This is generally not the case with tension type headaches. Chronic migraine is, along that same line, is often relieved by pregnancy, or at least alleviated slightly with pregnancy. Both chronic migraine and chronic tension type headache patients can use excessive analgesics, meaning painkillers, and this can lead to medication overuse headache in both subtypes. Chronic migraine patients do tend to respond better to anti-migraine medications, being the triptans, and both chronic migraine and tension-type headaches have a higher risk of psychologic comorbidities, and I'll go a little bit into detail later as to which comorbidities those are. So another diagnosis on the differential of a primary long-duration chronic daily headache is something called new daily persistent headache. So the diagnostic criteria for this is a sudden onset. So this headache starts, and within 3 days of the onset, it's daily, as opposed to migraine tension-type headache, where patients usually have an episodic history that then increases in frequency until they reach daily. New daily persistent headache starts as a daily headache. While it averages 15 days a month and it averages greater than 4 hours a day, these patients often have headaches all day, every day. That's generally constant in terms of its location, although it can fluctuate in its severity. It cannot meet criteria for Hemicrania Continua, and it's often preceded by a viral illness, trauma, or major operation. So new daily persistent headache patients will often come to the office and will say to you, 2 weeks ago, Friday, I had a headache that wouldn't go away. Or I remember on January 16th, 2011, I developed a headache and I've had it ever since. So these are patients who don't have a clear episodic headache history, suddenly develop a headache, perhaps in the setting of a viral illness or major operation, and it just never leaves. So the last of the differential is a diagnosis called Hemicrania Continua. Again, like all of our previous diagnoses, the headache has to be daily for at least 3 months, and the criteria for Hemicrania Continua is very different than the others. It's a side-locked pain, so it's unilateral. So let's say it's on the right side, and it never moves to the other side. It's daily and continuous. There's no pain-free periods. And generally, the baseline pain is moderate, but these patients get painful exacerbations on top of that. Those painful exacerbations can last hours or days, and along with the excessive pain, on that same side of the pain, they can have what are called autonomic features. And these features are a redness of the eye or tearing of that eye, nasal congestion or a frank running of the nose, as well as ptosis, which is a drooping of the eyelid, and miosis, which is a shrinking of that pupil. So during their painful exacerbations, these patients, you can look at them and tell that they have hemicrania continua. So the prevalence of chronic daily headache, and this is all comers, so any of the 4 diagnoses that I just went through, in the general population, if you ran into people on the street, it'd be about 4%. When patients are going to a primary care doctor for headaches, that estimation increases significantly to anywhere from 20 to 40%. When you take it further and you go to a neurologist's office, or even still a headache center, that number jumps exponentially. The numbers that are collected say 30 to 90%. On average, it's about 60%. So 60% of patients that come to a headache clinic such as my own will have chronic daily headache. So it's quite a high number, and it's certainly more prominent than what we see in the general population. So there are risk factors for chronification. Chronification is essentially the transformation from episodic headaches to chronic headaches. The frequency and duration of your attacks. So if someone has 4 headaches a month versus someone who has 10 headaches a month, that person 10 headaches a month is more likely to progress onto 15 or more and thereby become a chronic daily headache patient. Patients that overuse acute therapies, and I'll tell you in a minute exactly what overuse is defined as, they are more likely to develop chronic daily headaches. If a patient has comorbid medical diseases, if they're highly allergenic, if they have asthma, thyroid dysfunction, high blood pressure, obesity, snoring or sleep apnea, or previous head injury, we know from studies that these patients are more likely to develop chronic daily headaches than patients that have the same number of headaches initially but don't have these comorbid conditions. Lifestyle, so people that drink caffeine regularly, alcohol regularly, are frequently deprived of sleep, and have a low education or socioeconomic status are more prone to develop chronic daily headaches. And finally, females, just by birth, are at increased risk of going on to develop more frequent and eventually chronic headaches than their male counterparts. So I keep referring to medication overuse. So just to tell you exactly what that is, because it's surprising to patients how low these numbers are. So by definition, if you use an ergot or a triptan, so triptans, Imitrex, Relpax, Zomig, Maxalt, any of those triptans, on 10 or more days a month, so that's about 2 days a week, you fall into medication overuse headache. If you use opiates, so Fioricet or Excedrin, more than 10 days a month, the same thing is true. If you have simple analgesics, so Tylenol, Advil, Aleve, any of those, on 15 or more days a month, then you are in medication overuse headache. So headaches that seem to have worsened in the setting of increasing medication consumption is always a good indication that you're in medication overuse, as well as once stopping the abuse, if your headaches improve. So as I discussed, there are psychiatric comorbidities of chronic daily headache, including depression, generalized anxiety disorder, bipolar and panic disorder, as well as somatoform disorder. So conversion disorder and hypochondriasis can put you at increased risk for medication overuse. In terms of treatment, the only therapy that has thus far been proven to be effective in chronic migraine, so again, this is just migraine and it's chronic migraine. There are many oral medications on the market for episodic migraine prevention, but Botox, which is Onabotulinumtoxin A, has been FDA approved for the usage of chronic migraine, for prevention of chronic migraine, based on 2 prospective placebo-controlled randomized clinical trials given 155 units over 31 injection sites, and I'll go through those sites in a minute, with 40 additional units used at the discretion of the physician. And these big words down here are the muscle names that are injected into. So we do the forehead, which is the frontalis, the corrugators, and the procerus. We do 4 injections into the temporalis, the occipitalis, which is the back of the head, the cervical paraspinals, and again the trapezii. So these are the standard injection sites that physicians use based on the protocol that was done in the study that proved Botox to be effective in the prevention of chronic migraine. You can then give additional dosages in the temporalis, the occipitalis, and the trapezii as needed based on where the patient's peak pain is. This is generally done every 12 weeks, so every 3 months, as a prevention. So these are the oral medications that have been proven effective in the treatment of episodic migraine. We use them in chronic migraine as well. So when it says A next to a medication, that is our highest level of evidence. So Depakote, Topamax, and then again down here the beta blockers, propranolol, metoprolol, and timolol all have our best evidence for the prevention of episodic migraines. Amitriptyline and venlafaxine have the second best, so these are often very frequently used for the prevention of episodic migraine. And then again, if you look down here at the herbal supplements, riboflavin, magnesium, and feverfew all have very good evidence. So level B evidence means that they are probably effective, whereas level A evidence means that they are definitely effective. Other than medications, Botox and oral medications included, there are certainly non-pharmacologic ways of treating chronic daily headache. Proper diet is very important. So eating consistent meals, having protein in every meal, not skipping meals. Trying to exercise regularly, keeping your body well hydrated, and getting a good standard sleep. So at least 8 hours, and what's just as important is going to bed and waking up at the same time, weekends and weekdays. Migraine brains like consistency. Using a calendar. Calendars not only help you figure out your triggers, but it also helps patients realize how much medication they're taking and how frequently, because often they're not aware of it until it's written down. In terms of alternative therapies for prevention, biofeedback, as well as cognitive behavioral therapy, both have very good evidence in the prevention of chronic migraine, so it's often something that we use in conjunction with medication management. Physical therapy is also very important. Many of our patients have tension in their neck and shoulders, and physical therapy to help with proper stabilization and positioning of the head and neck can be very beneficial in chronic headache patients. And as I discussed, the herbal supplements, magnesium, riboflavin, and feverfew in particular, have very good evidence in terms of prevention of headache. There are refractory cases of chronic daily headache, at which times somewhat more extreme measures are used. Sometimes patients are admitted to the hospital for a medication called DHE, which is given intravenously, or prochlorperazine, which is compazine, which can also be given intravenously in the hospital. IV valproic acid, followed by IV Depakote. IV lidocaine can be given in extreme circumstances under cardiac monitoring. Alternative procedures such as trigger points or nerve blocks can be given in an attempt to help patients break the medication overuse. And finally, true, more invasive procedures such as vagal nerve stimulation, occipital nerve stimulation are being done. We don't quite have enough data to say one way or another, although some physicians do find it successful in their clinical practice. The prognosis is very guarded for chronic daily headache. It very much varies from one patient to another, which has been demonstrated in numerous studies. We can't really come up with a number. We know that medication overuse needs to be removed in order for patients to truly improve, and that most often behavioral approaches in addition to medication management is the key to a successful recovery. If patients stick with the plan, often up to 75% can gain prolonged benefit. But when my patients get better, we always keep an eye on them, and I follow up frequently because recurrence is definitely something that we need to look out for and be wary of. So that's all I have to say.
All right, well, we will open this up to questions then. And just so everyone knows, we will be posting this entire webinar onto YouTube by the end of the week. So if you missed anything, you'll have a chance to go back and watch it and listen to it as well. Our first question actually comes from Rosie. And the question is, as one continues to get bad headaches over the decades, is there an effect on one's pain threshold?
So there's actually sort of a twofold answer to that. Many patients become tolerant to the pain and start to accept the level of pain that other patients who would get it episodically would not tolerate. Having said that, when someone has daily pain, they get a condition called central sensitization, where their brain stem is always in a setting it's on. And that can often lead to a hypersensitivity to touch and to smell and to light that persists. So it's sort of it goes both ways.
All right, and our next question comes from Lauren, and she asks, I have used triptans since they became available, and they have been great. I have had reoccurrence often 4 or 5 days in a row, so I have tried to stop using them unless absolutely necessary. I seem to have more headaches now and wondered if there is any evidence to suggest that prolonged use of triptans actually increases the occurrence of migraines.
So as I touched on, medication overuse definitely puts you at an increased risk of getting more headaches. So keeping that triptan number to 2 or less a week will help you to control your current headaches, but not overuse. Because yes, there is evidence that overusing triptans, so 10 or more days a month, will increase your risk of getting more frequent migraines.
All right, and our next question comes from Lynn. She says that she is 61 and started with migraines almost weekly 10 years ago, which quickly morphed into chronic daily headache. She hasn't had much relief over the years, and the headache increased in intensity. She's tried a lot of things from different headache doctors, and she's now trying acupuncture with the addition of Chinese herbs and medicines, and she's finding some relief with that. Do you have any experience with patients with this, or any suggestions along that line?
I certainly have patients that have benefited from acupuncture. The evidence for acupuncture is not as strong as it is for biofeedback and cognitive behavioral therapy, but there are positive studies suggesting that acupuncture is helpful. Regarding the herbs, I can't really touch on that. There's always a concern amongst the physicians that something that's uncontrolled and therefore, we don't know exactly what the ingredients are, is a little nerve-wracking to us because we don't know exactly what you're putting in your body. So I just remind you to be wary of those things. Just because they're not prescription doesn't mean that they're not potent and potentially dangerous. So just be wary. But acupuncture, absolutely.
Our next question comes from Karen. She's 55 and her migraines started episodically, triggered by hormones, and progressively worsened over 10 years. 4 years ago, they transitioned to daily. Her last period of migraines was 2 years ago, and she has nausea and light sensitivity. Her lifesaver is Botox, but she's wondering how long can she continue Botox? She's had 6 treatments in the last 20 months. So
Botox is the newest migraine prevention that we have. The studies have just been out, and they are now doing the more long-term studies. Again, because it's newer medication, we don't have 20 years of data on it. We are starting to collect the more long-term follow-ups. Having said that, knowing about the pathophysiology of how Botox works and why Botox works, there's no reason to think that there should be any endpoint to your treatment as long as it continues to work for you.
All right, and following up on Botox, Laura mentions that she is worried about Botox because she doesn't want to deal with frozen face, but the injection points are exactly where she suffers from most. Are the doses of Botox used for migraine different than the doses used for cosmetic procedures?
Good question. So we actually use more in terms of the units of Botox applied, but we spread it out much more widely than the plastic surgeons or the dermatologists. So the forehead points, sometimes we can get a softening of the forehead wrinkle, but generally it's not a completely frozen face. And that is the only place where you will see any cosmetic results from Botox given for migraine. The other points, the temporalis muscles, up above your ears, the back of the head, the neck, and the shoulders have no cosmetic benefits. You don't have any wrinkles there to flatten. So really it's just the forehead where you would see anything, and most patients notice perhaps a softening of the forehead wrinkles, but nothing dramatic.
Barbara is wondering how effective biofeedback is in the treatment of new daily persistent headaches.
Biofeedback has been studied for chronic migraine. Unfortunately, with new daily persistent headache, we don't have that much data, and that is because the numbers just aren't large enough to really come up with powerful studies. So what we generally do for most chronic daily headache subtypes is apply the data that we know for chronic migraine. And we know that biofeedback is very beneficial, especially in conjunction with cognitive behavioral therapy in chronic migraine, which leads us to believe that it would also be extremely beneficial in new daily persistent headache.
Another Botox question coming from Candy is, can Botox stop working or stop being effective for a person?
It's certainly possible. Lots of medications can eventually, you need to increase the dosage and build up a tolerance to. We see that less often with Botox because generally over time the muscles that we are weakening are weaker on their own. So if anything, the longer we do it, the more effective it is. But I can't give a blanket statement and say that won't possibly happen with Botox.
James asks if you have any thoughts on the new Cephally device to stimulate the trigeminal nerve for chronic daily headache.
So nerve stimulation is something that we resort to sort of as a last minute, only because the data is not strong yet and because it's one of our most invasive options. So we always try alternative therapies, medication, lifestyle modifications before we send a patient for any sort of invasive procedure. Again, because the jury is still out on their full effectiveness, and they certainly have come with the most risks as side effects.
We have two people asking about the availability of Butterbur, especially since it was recently endorsed in the Journal of Neurology as Petodilex, which is still available online.
So this is the story with Butterbur. Butterbur has good evidence for the prevention of migraine, better than magnesium, better than riboflavin, better than feverfew. However, there is a metabolite of Butterbur that can be toxic to the liver and carcinogenic. There was a company that produced Butterbur and was able to regulate it and control for that metabolite and test its products to be sure that it was not in their products, and we used to recommend them. However, they switched their manufacturing and they no longer do that testing. So in the United States, we can no longer tell you that there's a safe Butterbur on the market at this time.
Michael has asked, I've been taking daily sumatriptan for several years under the direction of a neurologist. It is the only thing that has kept me functioning. Should it be a priority to get off?
Taking a medicine that was made to be taken acutely, meaning on an as-needed basis every day, is pretty much never the right thing to do. I don't know your whole case, and I don't know your physician's decision process, but Imitrex is not made to be taken daily, and we really tried to avoid that at all costs. I would certainly try to get a preventative on board and see if you can cut down that usage, because over time the usage of triptans can increase your risk of stroke and heart attack. It can give you hypertension in addition to leading to medication overuse headaches.
We also have a question from Cynthia who asks, I've been told that my migraines will improve after menopause. What is your opinion on hormone replacement therapy and migraine treatment?
So we generally do not recommend hormone replacement therapy in migraine patients. If patients go through natural menopause, meaning a menopause that was not from a hysterectomy and oophorectomy, then 2/3 of those women will get better following the perimenopausal period. When they're in the perimenopausal phase with hot flashes and night sweats, headaches can often get worse, but once those symptoms are over and once they've stopped menstruating, 2/3 of those women will get better with time.
Carol asks, what have you experienced with food allergies as triggers? I found that I have wheat, dairy, and triggers to fermented foods, so I have to have a very restricted diet.
So I always tell my patients that everyone is different. So having a certain trigger for one patient by no means means that you will have it for yourself. And it's just a matter of trial and error for each person. The jury is still out on gluten and lactose. If you have a true allergy to these things, if you have a lactose intolerance or you have celiac disease, then it is likely that they will trigger migraines. However, if you do not have GI symptoms when you're eating these foods but yet get headaches, it might not be the true sensitivity that you suspect it to be.
We have a few questions on new daily persistent headaches. One of them is that, is it possible that new daily persistent headaches will ever just spontaneously stop?
Yes, so new daily persistent headaches can go into remission. I actually have a few patients who we controlled well with medication, then tapered the medication off, and the headache did not recur. So that's something that's a little bit different than our patients that went from episodic headaches to chronic. New daily persistent headaches go from sort of 0 to 50, and they can go back to 0. Sometimes on their own, sometimes with medication, and then when the medication is weaned off, they're back to their baseline.
Someone else is asking if there are any new treatments for new daily persistent headaches as well. Someone is asking if you've heard of nerve decompression surgery for the treatment of new daily persistent headaches.
I have heard of nerve decompression treatment for the treatment of chronic headaches. I don't know of any studies that do it specifically for new daily persistent, although I'm sure it would be offered. And again, I feel similarly as to nerve stimulation. It's a fairly involved procedure that involves cutting into your scalp and nerves. There are some nerves that are proven to be compressed in situations like trigeminal neuralgia, where it's a tried and true procedure. When done experimentally for something like new daily persistent headache, again, I would choose to make sure that you look into your more conservative treatment options first, medications and lifestyle, before you put yourself at risk to an invasive procedure like that.
Leanne says that her son recently started taking migraine meds, and is an antidepressant recommended with migraine medications normally?
So there are actually quite a few antidepressants that are used primarily for migraine. So what I tell my patients when I prescribe them these medications is, yes, it will say on the label that this is an antidepressant, but it has very good evidence for the prevention of migraine. Amitriptyline and venlafaxine in particular, nortriptyline and protriptyline as well, have very good evidence for the prevention of headache, and they happen to also be antidepressants. But you do not need to have a history of depression in order to have them be given to you for your migraines.
Jan asks if there are any potential negative effects of using Botox to treat migraines.
Now, the side effects of Botox are very well tolerated. Other than, as I discussed, the softening of the wrinkles and the folds in your forehead, and a little bit of tenderness and soreness at the injection sites. Those are really the only side effects that we have really discovered. There's a theoretical risk of an absorption of the medication that we see in clinical practice. So it's really a well-tolerated option, especially for patients who tend to have side effects to oral medications and can't tolerate daily oral medications for one reason or another.
In regards to rebound headaches, Wendy says that, are there any over-the-counter meds that we can take that won't cause rebound headaches. I need help getting away from the ones causing rebounds, but the pain when not taking medications often becomes too much, and I end up taking more of what causes the headaches.
Right. I understand, and this is something that we see in headache practice all the time. We tell patients not to take something that makes them feel better, but then they're left feeling worse. Trigger points and nerve blocks are often a way that we can help people bridge out of overuse. So nerve blocks is a numbing medication called bupivacaine that we inject into the nerves that generally are the most inflamed and sensitive during headache. And patients are usually provided with 3 to 4 weeks of a decreased baseline pain, which enables them to decrease their usage of acute medications.
And Colleen notices that taking preventative medications have actually increased her frequency of migraines. She's tried a couple different kinds. Can you explain why that might happen?
So it might not be a side effect of the medication, but rather that her headaches had a natural progression of worsening anyways. You have to make sure that you're on a preventative for at least 6 weeks at a good standard dose before you declare it a failure. Some patients tend to get a little bit better before they get worse, and it takes time for the medication to build up into a steady state, which is why we ask that patients stick it out for at least 6 weeks so we can see its true benefit before stopping a medication. But if you've been on a good dose for 6 weeks and you find your headaches are worse, then it's probably in your and your physician's best interest to try another medication.
All right. We actually have a question from Chris, who is asking about magnesium in the treatment of migraine as a preventative. How much should he be using?
So that's a good question, Chris. So magnesium, the dosage that was studied for the prevention of headache is 400 to 800 milligrams a day. It's generally a very well-tolerated herb. The only issue is sometimes it increases GI motility, so it can lead to some abdominal cramping or diarrhea. It also affects the absorption of antibiotics, so if you were to be on magnesium, and generally we start at about 400 milligrams a day and work our way up if needed, then you'd have to separate the dosage of the magnesium from the antibiotic that you're taking.
You touched on this briefly before with acupuncture and some of the complementary therapies, but what's your opinion on the use of chiropractic treatments?
So chiropractic does not have any evidence in the prevention of frequent headaches. Not only that, but as a neurologist, I always am wary of chiropractors that do large manipulations. So if they do big manipulations that involve cracking of the cervical spine or back, knowing that your spinal cord lies within those bones and is being jarred pretty dramatically during those interventions worries me. So I would not recommend chiropractic maneuvers to most of my patients.
All right. Chris actually asked, I think this is a question we had right before we got cut off. If headaches occur daily and triptans should be limited to 2 times weekly, can an over-the-counter analgesic be used another 2 days per week as well?
No. So unfortunately, combining medications, it still gives you the number. So any combination of a prescription analgesic and over-the-counter analgesic, the number is still 2 days a week, 3 days on a bad week, no matter what the medication is. So you're still going to hit that number. And if you're having headaches 7 days a week and can only treat 2 days a week, then you have to have your prevention improved.
Mary says that she's on day 6 of a migraine, and her neurologist called in a prescription for a Medrol dose pack to stop the cycle. And she feels like this is a little weird since she's heard of it in using, as an inflammatory treatment. Is that normal?
So a Medrol dose pack, which is steroids, is actually used very frequently in the treatment of something called status migrainosus, which it sounds like is what Mary has. Status migrainosus is a migraine that lasts longer than 72 hours, so she certainly has fulfilled that and then some. Migraine does have a large inflammatory component. So what happens in migraine is when the blood vessels dilate, the vessel walls become weak, and inflammatory markers spill out of those blood vessel walls, and they attach onto parts of the brain that are pain sensitive. The brain itself is not pain sensitive, but the blood vessels that supply it and the dura that surrounds it is, and they get filled with inflammation. So steroids are a very good way of washing out that inflammation and getting you back to your baseline.
Vera says that she's been put on Cymbalta to take nightly. Have you ever heard of using that as a treatment?
So yes, I have. The data for Cymbalta is not great, so it's not an A or B. But you know, everyone's different, and in clinical practice, Cymbalta does have. We have seen some success with Cymbalta. So I myself have used it for some patients. You know, if they're not responsive to the A or B medications, then Cymbalta is certainly on the list of another possibility.
Teresa says that she's taking Lyrica as a preventative, but fears that it will be very difficult to wean off of eventually. Do you have any suggestions in that regard?
Lyrica does need to be weaned off in a slower fashion, as long as it's done as scheduled by your physician and you. Generally, it's not very consequential in terms of withdrawal. It's a good medicine for headache and often is good for overall body pain as well. I always tell my patients when they're on a medicine that's working, don't immediately start thinking about coming off of it. Just let's get you better first, let's keep you better, and then as a team, we'll come down from it when you're ready, and we'll do it slowly and so that you're comfortable the whole time.
Mark has been suffering from chronic migraines for about 6 years, but hasn't heard nerve blocks spoken of before. How new is that treatment, and how reliable is it in terms of a treatment for chronic migraine?
So nerve blocks are not that new, but they are only done by trained physicians. So usually it's pain or headache specialists that know how to administer them. And the data is good, although not great. So I always tell my patients, you know, I'm not going to promise you a cure, but if this gives you relief, it will last 3 to 4 weeks, and it will help you come off of your Fioricet or your Excedrin or your Imitrex. And it's very well tolerated, and the side effects are minimal. Essentially, it's just some pain at the site of the injection and numbness of the head, which many patients that suffer from chronic daily headaches would love a little bit of numbness of their head.
Jackie says that her 14-year-old daughter has had migraines since she was 2 years old. They became chronic about 2 years ago or so. They're working with a neurologist currently, but they wonder when you suggest someone should go to the hospital or the ER to try and break a migraine.
So going to the hospital is always hard for chronic headache patients because they have a headache all the time and they don't know when to essentially pull the trigger. If you can't keep down medication, if you're vomiting up either from the pain of your headache and you can't keep down any of your analgesics, you might need to go to the hospital not only to get IV medication but also to get rehydrated. If your headache is different, if it's more severe, if it's in a different place, if it's not responding to the medications that it normally responds to, just because you have a primary headache does not preclude you from having a secondary headache. So that should be taken as seriously as in a chronic daily headache patient as it is in a patient with no headache history.
So Robert has been on Fioricet for over 2 years at least 6 per day. And how slowly do you need to taper off of a medication like that?
So Fioricet is one that we do not take lightly. It has an ingredient in it called butalbital that if withdrawn cold turkey can lead to seizures. So Fioricet needs to be tapered down very slowly, and often a medication called phenobarbital needs to be replaced while you're tapering it down so that you don't have seizures. So absolutely talk to your doctor about the safest way to do it. It's not something that you can just stop one day.
Laura actually asks, how long do nerve blocks last, and how often do you have to go and get more injections?
So best case scenario, they last a month. For some patients, they only last a week or 2 weeks, in which case they weren't really successful because it's not something that we can do every 1 to 2 weeks. Nerve blocks are safe in pregnancy. For some patients, we do them once a month while they're in the first trimester pregnancy, which is often the hardest, and then their pregnancy can carry them through, and usually their headaches improve in the second and third trimester. So generally, if they're successful, they should last 3 to 4 weeks, and then we can do them about that frequently.
Is there any medication that is particularly effective for chronic migraine with aura as compared to just chronic migraine?
So the only thing that's interesting, we always use the chronic migraine medications for chronic migraine with aura. Generally, when a patient has chronic migraine, they don't have auras with every headache, so they shouldn't be having 15 days of aura a month. If that's the case, you should definitely double check with your neurologist and make sure that you are in fact having migraines every day and not something else. Having said that, Lamictal, which is a medication that has not been proven to be very effective in migraine, does have more benefit in migraine with aura, which is just something of note. But again, a chronic migraine patient generally does not have chronic auras, so make sure that that's what you're looking at before you think about treatment options.
Gary asked if caffeine in coffee stops his migraines. Is that better than taking something like Fioricet?
So caffeine is an ingredient in Fioricet. I would much prefer you take one ingredient in Fioricet than all three. So Fioricet is caffeine, Tylenol, and butalbital. If you can just take the caffeine out of it and that treats your headaches just as well, I'd much prefer you use one ingredient. When you start doing combination therapies like Fioricet and Excedrin, that's what increases your risk for rebounds and medication overuse.
Dr. Mullen, thank you very much for joining us tonight and giving this presentation as well as answering so many questions.
You're very
I think
welcome.
we're going to end here. Yes, thank you again. You were
I'm so sorry
great.
about the difficulties.
Oh, no problem at all. And just so everyone knows, we'll have this up on YouTube and just probably at the end of the week, so you'll be able to go back and look at all the slides that she presented as well as answers to these questions as well.